Hello and welcome to the Orthoclips podcast series. I'm Saqib Rahman, and today I am with Dr. Faseeh Shahab. He's consultant orthopedic surgeon at the Shahab Orthopedic and General Hospital in Peshawar, Pakistan. And we're going to be talking about management of infected non-unions. Dr. Shahab, salam alaikum, and welcome to the podcast.
Wa alaikum salam. Thank you very much for this opportunity.
Great. Well, I wanted to ask you, how did you get, we're talking about management of infected non-unions. These are challenging cases. So how did you get interested in doing these cases? And perhaps you can give us an anecdote or a story or maybe an example of a patient that you treated early on that kind of got you interested and exemplifies what's become a part of your practice.
Well, these patients who with infected non-unions, actually, in early part of my training, I used to see a lot of these. There was a very high volume of such patients coming who were treated not only in the northern part of Pakistan, but also coming from Afghanistan at that time, because Peshawar is the main city in northern Pakistan, as well as gets a huge inflow of patients all over from Afghanistan as well. So we used to get a lot of these patients, and these patients had something in common, that they had so many number of procedures they have done before. Some would come with, like, say, 4 or 5 surgeries beforehand, and also some would then one surgeon would treat them once, and then when the patient doesn't get better, they send it to someone senior, and at the end they would come over. And my father, being one of the senior most orthopedic surgeons in the province, as well as country. So most of people, well, they would end up coming to us at a time. The most important thing about these patients were, they had undergone so much sufferings from repeated surgeries, and because we're from low and middle income countries, as you know, once the bread earner gets injury, so the whole family spirals into poverty. So treating these patients was not only just from orthopedic point of view, but also from community point of view, was very important. And these patients were a bit very challenging. Well, I do not recall a single patient who did it, but there were a number of patients who would come in a very bad shape, and after treatment, say, for example, 6 to 8 months, and after that, and when they would get better, and they were, for some reasons, they gave more proud as they made the surgeon more proud, as well as there was more thanksgiving than what, say, for example, a simple tibia fracture, simple femur fracture, simple trauma patient would come in that time. So, and then again, going into the literature at that time, there was evidence, but again, most of the cases at that time, the success rate is not as high in these cases as it is in those days, for example, say, primary cases. So that made me interested in taking care of these patients much more than simple trauma patients.
Okay, yeah, that's clearly become an important part of your practice, and I can see why you've gotten so many of these patients. So, as I mentioned earlier, I find these to be challenging cases. I'll give you an example of the situation that I find challenging is, you have a patient with a non-union, and we always are taught to always think infection. But infection is not that apparent. I mean, it's one thing if the patient comes to you and they're draining sinus or draining pus, or certainly if they have an acute component of their infection. But when they come in and there's really none of that, they don't give you any constitutional symptoms, but you still suspect and you feel you have to rule out infection. What's your workup? How do you go about deciding if there's an infection going on for that case that's not so clear?
Well, that's a pretty interesting question. Yeah, as you mentioned, well, the simple blood workup of ESR, CRP, WBC, as well as discharge or sinus formation, well, that clearly points towards infection. But at times, there are patients who are asymptomatic, and they don't have any constitutional symptoms. But when you ask them, they'll tell you it's been 18 months or 15 months or over a year, and the fracture is not healing. And this is something which Paul Tornetta wrote about 10 years earlier, that even some of the cases in which the bone's not healing, even you can find infection over there as well. So in such patients, yes, there is some like hidden infection, you can say, for that. Um, Also, the fact that most of the patients, well, when they get operated by surgeons who are not very well trained, or they don't have enough facilities, say, for example, of doing percutaneous reductions or doing it close nails, all that. So they do tend to open up the fracture site, and they tend to strip off the whole periosteum. Well, we kind of refer them to as like stripping off like a sugar cane, for example. Let's make the whole bone just white. And in some cases, well, the X-ray would look just fine, and the patient would may not have any symptoms, but he would be in a state of non-union or very delayed union, say over a year, 2 years, and bones not healing. So that's one way. In such cases, yeah, we find such cases a lot of these having certain infection, and treating those in revision surgeries. We also did find many patients who had the fibrous tissue in the fracture site that turned out to have bacteria when we sent them for microbiological tests. So in non-union cases, there is a high chance of infection.
Now, what about imaging? I'm sticking on this question of workup when you potentially suspect infection. Are there particular imaging studies at all that you find to be helpful, or are there imaging studies that you've kind of discarded because they really haven't proven helpful?
Well, other than when on X-rays, like we like those, there are some like trademarks of of non-unions, like sclerosis of the fracture site, a gap in the fracture site. CT scan at times can help if there's a sequestrum over there. But again, most of the patients that do present, well, if you want to have a CT scan, most of them are not willing because of the additional costs. MR, we don't have facilities to have those. MRs in which there's a metallic implant and we can still get a MR imaging. So we for this matters, it's really we do go move beyond CT scans for these cases.
Right. Now, so they have a non-union, so you've decided you're going to need to treat them, and in the back of your mind, you're thinking that there's always the potential maybe this is infected. And again, we're talking about the case that's not obviously infected, not draining sinus, no acute component. So in those cases where it's not obviously infected, but you're culturing it just to be complete, and maybe something comes back positive, or maybe it doesn't, does that change your treatment? For instance, if you're just treating a non-union with revision fixation, a revision nail, revision plate, do you do anything differently? Because in the back of your mind, you're thinking, this could maybe be infected and I don't want to find out later on and I didn't do something. For instance, are you doing any antibiotic cement on your implants when you do these non-unions as a matter of routine because you don't know if they're infected?
Yeah.
Curious as to how you handle that.
Well, in most cases, we kind of do these with sign nails. Sign nails, as was in your earlier podcast with Dr. Leo Zirkel, we use sign nails, just stainless steel nails, which are solid nails. Um, in such cases, so the idea of even infected non-unions, the idea is to remove the biofilm, because the biofilm is such that it kind of inhibits the antibiotics to reach to the bacteria. So, and in sign nails, what we do is we do hand reamings. And I really do believe, well, I don't have any data on that, but I really do believe doing hand reamings and can really like take out all the biofilms from inside the canal. And then in treating these non-unions, we have like after doing non-unions, you can have addition of bone grafts. We do not have access to BMPs because they are of very high costs here. I've never used BMPs in my practice because of the high cost. But yeah, bone graft as well as intramedullary nail for most of the fractures for the femur, tibia, humerus, they work pretty well. And if the culture comes back positive, because it takes about a week from when we send them to the lab. So if even that comes positive, we then just go along with the culture sensitivity report and then give antibiotics to the patient according to that. But at the time of surgery, it doesn't matter if the patient has like it's not it doesn't have an obvious infection, say for a discharge or sequestrum. the treatment plan for this case is the same. We try not to do it in two stages because of financial constraints. We just do one procedure, take out the implant, do intramedullary nail after reaming and putting in bone grafts. And we have a series. Some work of it was published a few years back, and another work is in the process of compilation for publishing. So we have had pretty good results with this technique.
Got it. Interesting. You've already alluded to this a little bit, but I wanted to ask, what are some of the particular challenges being in Peshawar, Pakistan, with managing some of these complex cases? For instance, you read these papers, you go to these conferences, and people are saying, we're doing this and that, and this is our algorithm. How have you sort of adapted, I guess, to the constraints you're dealing with in order to meet these challenges of these cases?
Well, in my opinion, like there are two main constraints. Number one is out of the pocket expense of our patients, because our patients have to pay from their own pocket. So, the most choices are not evidence based. We give the patient options, and then he has to pick based on his financial status as well. Keeping the same thing in mind, some of the patients, the antibiotics, there's some of the high potential, the high class antibiotics are of high costs, and patients, when they start getting antibiotics, just when they think they are getting well, they just stop it even after 2-3 days, and then that again leads to resistance against a bug. And then again, the antibiotics are freely available in the market. Anyone can go and buy whatever antibiotic he wants. So self-medication again is an issue, because in Pakistan, there's a big trend of using linezolid, antibiotic for all Staph aureus, MRSA, and all that, and it's very widely used. Even for children's, pediatricians just try it. If there's a small skin infection, it's not healing well, they just go right directly to that. And we are seeing a lot of cases these days in which the whole culture sensitivity report is all resistant to over 20 antibiotics. So it's one of the biggest challenges we have for treating such patients. Again, for the second surgery, if there is a bone defect, we do a lot of masculate technique. We're putting in bone cement as well as antibiotics. And again, we have limited access to bone banks. There are just a few in the country, and sometimes we in our setup we kind of use allograft from a patient who was supposed to go buy prosthesis or a total hip orthoplasty. We take their heads, and then if needed, we use that as well as an allograft. But even that's very scarce and very limited, and it's not readily available to most of the surgeons as well. And BMP, as I alluded earlier, is pretty expensive. So all in all, so antibiotic resistance as well as expenditure on part of the patients are the two limiting factors, because sometimes we would want to have a particular surgery for a patient, but he would not be able to afford it. So then we have to go to a plan B.
Interesting perspective. A lot of interesting techniques. What are some of and it'll probably wrap up with this question, what are some of the future directions that you foresee in the treatment of these patients? Anything on the horizon that in another 5 years you think we'll be doing differently, or where do you hope we'll be going, if you want to be a little optimistic with management of infected non-unions?
Well, I think in cases of like a two-stage revisions, in the first stage when we put in an implant, and then the aim of the implant is to provide stability, but to eradicate infection by having a high concentration of antibiotics, which elutes into the surrounding bone, and then after a while we have to take them out and then put in a definite fixation. I think there may be an implant which would keep on eluting antibiotics for a time, and or we can without undergoing a second surgery, if we could somehow refill it with antibiotics, so provide local high concentrations, that could be one. Training surgeons is pretty important, because if a patient gets treated primarily in good hands, he may really go into these complications. Well, non-union can happen, but infection is highly preventable and can be prevented if we have. Unfortunately, we lack data in Pakistan regarding optimum antibiotic formulations as well as combinations for treating antibacterias. I think if we can have policies not in Pakistan but in other places as well, that could help. And again, we would be interested in, for in such cases, Elizarov technique of circulating external fixator has shown some pretty good results, and also masculine technique has shown pretty good results. There have been studies comparing both, and I think in resource limited settings, either of the two techniques work well. And if surgeons who are trained in either of the two can do pretty well. So we have to like train surgeons, especially in these two techniques.
I agree with that. And yeah, hopefully we'll get there. I think we'll probably wrap it up there. To listeners, I've been chatting with Dr. Faseeh Shahab from Shahab Orthopaedic and General Hospital in Peshawar, Pakistan. Dr. Shahab, it's been a pleasure. Thank you for coming on the show.
Thank you very much. Thank you very much for the opportunity.